All right, everyone. This is Dr. Hawley, Brian. A lot of you guys know me by. We are starting here. We have it on recording, and this time I am remembering to hit record. The last one that I did, it was actually about an hour and a half webinar. I had to redo all by myself because I didn't record it, even though the live session was awesome. So this one here, I am making sure I'm recording for you guys. What I wanted to do is talk about diabetic neuropathy. Again, I was talking privately with the groups that were on earlier. We were kind of chatting back and forth. It's one of the most prevalent things, especially in the developed countries in the third world, or not in the third world, but in the U.S. It's one of the most prevalent issues that we're facing as a healthcare. I'm going to say a crisis now. And we're actually seeing more and more. When I was seeing a lot of pediatrics at one time in my practice, I was starting to see more and more juvenile diabetes. So I wanted to get this out there for the massage therapy group that we do a lot of the trainings for and we talk with. And my wife and I used to teach at a school part-time. We would go on in and do private lectures to the students and go over things. And this is one of the things that a lot of them would talk about because they didn't really hit it hard and heavy in the schools about diabetes. You know a little bit about the endocrine system, and that was about it. So what I wanted to do is cover a little bit more in depth on that, okay? So I'm going to hit a little bit about the pathology, some of the physiology, about the islets of Langerhans. Does that have anything to do directly with how much pressure you're going to use? No, okay. Well, maybe. We'll get into that. But what I believe you have to know a little bit about the condition that the client's coming in with to effectively treat them, and then how to know how to manage the client as a case presentation, and also know when to refer and when to co-treat and when not to treat. So we're going to be covering some of that. And then I had a epiphany yesterday morning. I was thinking about it. My wife and I were talking, and I told her, I said, it doesn't do us any good to go ahead and go over this stuff and then not tell them how to get the word out to the community. And I got to be honest, a lot of you guys have seen our ads. My staff does all the emailings for me. I know they've emailed out some Facebook marketing and stuff. So I told my wife, instead of doing a separate thing, let's just go ahead and do, how great would it be to do the webinar, tell about the condition, educate them on the condition, what we've seen in our clinic, how we treated them in our clinic, and then showed how we marketed to the community. To me, that would be a full circle webinar, and that's what I'm going to do here for you guys. I want to do the full circle one, so I hope you guys don't mind that. Oh, I'm getting a lot of no, cool. Hey, oh, speaking of this, I hardly ever leave the chat sessions on. But if you guys are all right with it, we have about 100, just almost 100 people on this right now. So if you guys are all right with it, I'll leave the chat and the question things on. But what I don't want to do is have it where everybody's asking at once and we can't get through the material. So normally I don't leave it on. So if you guys are cool with that, let's go ahead and do that. We'll leave it on, okay? So let's go ahead and begin here. And I think I got my cell phones. One last tech check here. Everything's good to go. All right. All right. Here we go. So a lot of you guys, I recognize the emails. You've been with me on many of my webinars. We've been doing this for about 5 years now. 7 years speaking live. So we're going to be doing that. A lot of you also don't know who I am. So let me tell you who I am. And first of all, this is not me dressing in drag on the left. Okay, that's not me. I'm the old guy here. So I've done a lot of public speaking and everything in over the years, and we've had 7 clinics going. I went to med school prior to chiropractic school, worked in hospitals for years, got burnt out in ER, had to do something where people aren't coded on me, so I went to chiropractic school and actually taught while I was going to chiropractic school, taught phys die and other things. And this is my wife, Jody, over here on the left. She ran a massage studio, had several massage therapists, acupuncturists, and a oh gosh, I was going to say a reflexologist out of her office. She did that, and she also did it. She was maybe a stone's throw away from our clinic, and we did a lot of co-treatment. Prior to opening on that, she actually was the clinic administrator for me and all my doctors, and she actually headed up the back rehab, where we had extensive rehab and we did ART, PNF stretching. So she's been a massage therapist for about 5 years, but in the healthcare since the late 80s, seeing the cases and working with me. So I lean on her for a lot of, I'm going to say inspiration and to tell me what to do. We've been married over 30 years. So that's kind of who I am. And now I sold my practices last year, at the beginning of last year, and we moved out by the ocean. You can see I took a shot of the ocean. So I do a lot of my course development on the ocean. I know, tough life, guys. I know. I'm getting some heat from the chat session here. I know. But I sold that, and now I do webinars and I do lecturing, and I have clients that I do private marketing for via the computer, and we're enjoying things. So now we're trying to give back a little bit. So we're also probably going to be doing some, I'm wanting to do some live seminars. I just got invited. I'm the national advisor for Pivotal Health Solutions. I do all their decompression advising and their lecturing for them. And they also own another company called Custom Craftworks, and they manufacture a lot of the massage tables and accessories. So they're wanting me to actually host a live seminar and use their facility where we have like 30 already set up massage tables. So if we do decide to do that, I'll send an email out to you guys, and what I'd like to do is like a 2-day medical massage pre-certification course where we just go through I'm getting a ton of stuff. Yes, yeah, it's not in the works. I'm getting a lot of questions on that. It's not in the works, but we're really thinking of doing that because I think that would be a cool thing to do, okay? Then we'll do like a big testing afterwards, and you can hang a plaque on the wall. So I think me and a couple of the docs might even do that. So if we do, I'll send an announcement out. So let's go ahead and get started. Housekeeping, a lot of you guys know this. Give me time, because after this I got to convert it, or actually I give it to my staff. We'll get it converted and they'll get it uploaded, and then we'll send out a private link where it's going to be located, and we'll get our notes and we'll send them all out. So give me some time afterwards, you guys that are on our live portion right now. And so you should have them by tonight. If for some reason you don't get it tonight, everyone here has my email. Shoot me an email, and you can also get me right there. It is. Let me do a better email than that here. Hold on, guys. I'm going to change this. Let me see if I can do this. I want you guys to email me at see if I can do this. See if I can do this live here. Now, I'm coming up with another screen. info@drbrianhawley.com. So go ahead and email me there. That's the one that I check all the time now, so do that. Or the hawleybrian@yahoo.com. A lot of you guys have that. Just email me and say, hey, I didn't get those. Would you resend? Because sometimes I have no idea. I'll send this out, or my staff will send it out in a bulk email. Probably 5 or 10 people will not get them, even though they're on the email. I have no idea why, and it doesn't go to spam. I think it's like the socks and the laundry. You always miss one. So no telling. So no harm, no foul. Just shoot me an email, and I'll just privately send it out. No big deal. Normally I have the thing checked off for questions in chat, but I'm going to leave it on for you guys today. It's Friday. What the hell? So we'll leave it on so we don't have to worry about questions. Just kind of take it easy on them so we can get through this. Certificates, if I can get them, if I'm at the computer, I'll go ahead and look at your tests. And yes, speaking of tests, when I mail the notes, I'll send a test along with the notes. Just go ahead and email me back the answers. You don't even have to try to photocopy the test. Just say number 1 is A, number 2 is B, number 3 is C. That's all we need, and then we just check it off on our master answer key, and we'll send you a certificate. So we'll get all those out afterwards. And I think that was about it of the preliminary stuff that I had to go through. I hate doing housekeeping stuff, so we'll go ahead and get started on some of the cool stuff. All right. Some of the things that I wanted to show you guys, let me get all this up here as it's slowly coming up. All right. The age-adjusted prevalence, if you look at obesity and diabetes, they go hand, it's like bread and butter, right? They go hand in hand. And you can see back in '94, how it really wasn't that bad. It wasn't an issue. When I was a kid growing up, and I'm dating myself here, but when I was a kid growing up, we didn't have to worry about all this stuff. There was other things we had to worry about, but not this. Look at 2000, how it's starting. As we see obesity started going more, then slowly right behind it, we started having some diabetes. Now obesity is really starting to take prevalence, and this is 2013. You guys already know how it is in 2016. It's going to be worse. I think I seen a report, read some scientific literature the other day that this is the first generation that the kids are not expected to outlive the predecessors. I mean, come on, we're supposed to be educated society here, right? But we're not going to get on the nutritional soapbox because that would be a lot longer of a webinar. And I'm sure a lot of you guys would be chiming in on that too. But you can see it's definitely going the wrong direction. It really is. And this is taken right from the CDC. A lot of the stuff, if you want to get handouts or printouts, or you want to put like an ad in a paper or put an ad on like Facebook or something like that, you can actually use some of the stats right off of the CDC. There's no problem in using that. And there was actually some on there, and gosh, I wish I had uploaded it because it's really cool. You can actually, the CDC, the NIH, National Institutes of Health, and the ADA, American Diabetic or Diabetes Association, actually had a couple pamphlets, PDF little booklets that are free to download. So where am I going with this? If you have like a 20-page booklet on diabetes or prediabetes and it's an ebook, you could actually put that on like Facebook or Instagram or something like that and say, if you or a loved one suffers from diabetes or think you might, here is 7 signs that you need to look for, and download our free PDF. And then they give you the email and they automatically download it, which is cool. It gives you an email and you can start building a huge email list and start mailing out things about specials, or if you want to sell a pillow or lotions or oils, you can start building a business that way. But CDC, the world or the National Institute of Health, and the ADA, American Diabetes Association, they each had one of those when I was looking up some of the info to build the slides for this last week. So the other thing we got to look at too is cardiovascular disease. My gosh, it's leading cause of early death among people with diabetes. Okay, now keep in mind, adults with diabetes are 2 to 4 times more likely than people without diabetes to die of a heart disease or experience a stroke. Remember, the stroke is with the brain, the heart attack is with the heart, right? Okay. Also, 70% of people with diabetes will have high blood pressure. Sugar, just think of an enclosed pipe, and with fluid in it, the more salt, sugar, everything else, more solids that you put in that pipe that doesn't expand too much, the more pressure there is, right? So you run higher risks, okay? Which means the pump has to pump a little harder because it's higher pressure, and other things can go wrong like aneurysms and TIAs and CVAs and all those things, okay? So they're at a higher risk factor. Now, the other thing, diabetes mellitus and obesity, they do have a relationship. Like I said, there's like a bread and butter. Type 2 is the main one that has this relationship. Type 1 is kind of way off on the sideline with the relationship with obesity as far as the main statistics is. But type 2 is, or it used to be adult onset, because we didn't have those so much in children, but now with the obesity crisis with our kids, we're seeing more and more type 2 diabetes in kids now, okay? So obesity is one of the major risk factors for type 2. Further, obesity is a precursor within insulin resistance. Insulin, as we know, is a hormone produced by the pancreas. We're going to go into that a little bit more. The pancreas will produce the insulin to drive down the blood sugar levels that's in the blood, okay? Now, what happens is a lot of times whenever the obese people have type 2, the amount of insulin produced by the body may be normal. They can still have a normal output of insulin. But the problem is, due to the increased size, the increased hormone level that they may have, and we'll get into that in just a little bit, the insulin may not be enough. Even though to the all normal blood test, they still may be producing adequate normal amounts of insulin, but for them and their condition, it may not be enough. So they had to come up with a medical term for that. So that is called insulin resistance. Okay, so you can have insulin resistance diabetes. Okay, so you're still producing, pancreas is still functioning, you just don't produce enough, or the receptors on the cells have become so, I guess the lack of a better term would be numb, that they don't recognize it and it's not enough to trigger the response. Okay, now here's just a little bit of numbers I wanted to post in here. Basically in 2000, the incidence of diabetes worldwide was 171 million. Now studies are projecting by 2030, another 14 years from now, which isn't far, time goes by quick, especially when you get my age, it's 366 million. I mean, we're cranking this up. That's by the WHO. So yeah, we have an epidemic on our hands. We got to be on the rise for. So what does that mean for us as healthcare workers? More and more of our patient populace, whether we advertise to them or not, is going to be affected by this, and we got to learn a little bit about this when we're treating. Now, oh, and if you hear like a little pause, that's me taking a sip of water, since I'm the only one talking on here. I will need me to take a little drink of water every now and then. Being obese or overweight will increase the chances, right? So how does this, how does this make us become insulin resistant and everything else? So how does this happen? What the newest research is proposing, if you guys have had some cell biology, you guys remember, some of you guys just are probably more in tune to this than I am. Basically, this here is our cell with our nucleus. We have the mitochondria, which is our ATP, the power generators, the Golgis. Then we have our ER, our endoplasmic reticulum. And this here has like the little specks. That's the rough ER, okay, with the ribosomes and stuff like that. So what happens is being overweight stresses the inside, specifically overeating the members inside of the cells, the ER. When the ER has more nutrients to process, more nutrients are being inputted in the cell than it can handle, it sends out an alarm saying, whoa, whoa, let's dampen down the insulin receptors on the cell surface. Quit firing. I can't handle all the stuff that you're sending me, right? Now, what happens is, you go on a binge eating, say Thanksgiving afternoon, and you just have your eating pants on and you extend them like 2 inches. That's all right. It's not going to cause you to have diabetes in that one sitting. Even though I have had like grandma's pound cake that seemed like it could start that, because that thing was super sweet. But repetition of this over and over and over, that is what causes the receptors to be numb, to become stagnant. They get overburdened, and what happens is they become insulin resistant. So whenever that happens, they will not open the channel to let the sugar out of the blood. So what happens then is it stays in the blood. And then you have a whole lot of other effects that can happen. And then you get high blood sugar. So one of the things I read about, and I didn't put in here because it wasn't substantiated, but they're hypothesizing now that the little sugar molecules can actually cause nicks and abrasions inside the arterial walls. Like little, just think of, in my mind, when I was reading the article, I was envisioning breaking a piece of glass and you're having like little shards of glass running through your blood vessels. So kind of keep that in mind too. That could be a hypothesis, and they're trying to hone in and see if that's true or not now. Now, what about hormones? We all have hormones. It's part of the endocrine system. So further obesity can change the hormones. The fat will actually start producing its own hormone. Okay, so furthermore, obesity associated with increase in secretion of chemokines. If you guys remember some of your physiology, the histamine, the cytokines, the bradykinin release, that's all to do with inflammation, right? Substance P and all the inflammation stuff that can be produced. So we're finding now inflammation is a huge factor in a lot of our diseases, okay? So whenever you start producing the chemokines, this leads to activation of inflammatory cells like macrophages. Activated macrophages produce cytokines that can decrease insulin sensitivity and increase insulin resistance. So in addition to the ER saying, whoa, too much, turn down the insulin stuff, You also have this, which can create, being obese, can actually send out its own hormone, which triggers another cascade of kinin releases, which causes inflammation, which, due to the max, can actually also decrease the resistance, okay? So you have a couple things that can happen there. Now, another thing I wanted to mention was, what about pregnant women? You know, gestational diabetes, GD, right? Um, Nowadays, because of this, almost everyone, it's a routine to get tested for GD, gestational diabetes, okay? But the ruling, if you really ask the ones that are on top of this, what constitutes a normal blood glucose level during pregnancy, it's still kind of controversial because almost every pregnancy is a little different, right? We have different body types, age. I mean, there's a ton of things different. Twins, you know, there's a lot of things. But what happens with this is normally during the pregnancy, the pancreas will produce adequate amounts of insulin to regulate the sugar. However, what happens is the HPL hormone inhibits the body's ability to transport the insulin properly out of the bloodstream and into the cells where it's used as fuel. The resulting levels, the results would be elevated levels of blood or gestational diabetes. Now, can they still get massage, prenatal massage and all that? Yeah, they can. They really can. But you still got to make sure that, and we're going to cover this later, whenever you do a pregnant person that has gestational diabetes or suggestive diabetes, you have to take some precautionary measures as the same you would with any client that has diabetes. And we're going to get into those a little bit later, okay? But that's how gestational diabetes can happen in the pregnant female. Now, obviously, after birth, the placental and everything is excreted from the body, then everything should return back to normal within a couple weeks. Okay, you should have everything going back to normal. Okay, that's why it's just only during pregnancy. Now, again, keep in mind, I didn't want to go in, we're not going to go into all the other types of the things. We're going to talk a little bit about the pancreas, and I don't want to bore you guys with anatomy, so I'll try to make this as interesting as possible. So bear with me on this. So we had 4 semesters of nothing but endocrine, and oh my gosh, it was like the Ben Stye, the dry eyes versus clear eyes commercial at times. So basically, the pancreas is a little bitty dude, kind of right below your stomach right here. Okay, so it's made up of obviously a ton of cells. Well, the ones we're going to talk about is the islets of Langerhans. And they actually, if you break them down even further, they have alpha cells and beta cells. Okay, so what's the difference in these? Basically, what happens is the pancreas secretes insulin and glucagon, glucose, sugar. Endocrine cells of the pancreas are contained in the pancreatic islets or islets of Langerhans. They make up only about 1 to 2% of the pancreas. You know, they're not the prevalent things, but they're pretty darn crucial. Okay, they're scattered throughout. Now, the islets, the alpha cells, produce the glucagon, which is the sugar. Okay, so if we have hypoglycemia, we're getting low on blood sugar, they'll start producing some glucagon to stimulate, and we'll get into a little bit how that works, to raise the blood sugar up, okay? Or in like the fight or flight mechanism, and we're not going to get into all the hormones and the adrenals and all that, but that works in conjunction with that to get the blood sugar up, to get you ready to run or fight, fight or flight. Now, you also have the beta cells. They produce the insulin, okay? So, again, keep in mind, let me move back here, there. These cells only make up 1 to 2% of the mass of the pancreas. And that's all the body where they are. They're right there. That's it. So what happens if we start abusing these things by gorging 5 times a week, every meal? You're going to start overworking these guys, and they're going to start pooping out. They aren't going to have enough juice in them to keep going. So then you start getting insulin problems. You're not producing insulin. You can almost develop a type 1. So some of the people, when they're born, will have a very small portion of the beta cells, and they don't produce enough insulin. I have seen people with auto accidents, severe auto accidents with trauma. Afterwards, if they damage the pancreas, some of the area or some of it won't function as well. Obviously, it's life-threatening, but when they do come out, sometimes they can develop other symptoms, and this could be why too. Now, again, islets are heavily invested with capillaries. They're innervated by both sympathetic and parasympathetic, so our fight and flight and everything else, obviously, it has to work that way. Now, so what's an ideal thing? A lot of you guys already know this, and actually I read some more reports that now they're changing these numbers a little bit. They won't go ridiculously far, but you're in the ballpark here. Basically insulin and sugar act in an antagonistic fashion. So they, one kind of offsets the other. It's a balancing act. So the acceptable range is between 70 and 110 milligrams per deciliter. That's your blood sugar. So whenever you get your little finger stick and they put it in the machine, you really want it between 70 and 110. Will it go up after a meal? Yeah, it'll always go up after a meal. It'll spike up a little bit, but we don't want it to we don't want a huge spike because then you'll have a huge drop right afterwards. So that's why they say keep your meals small, frequent, low glycemic index foods will help with this, avoiding the spike. If you're going to have a carb meal, also try to have a protein with it. That'll buffer the spike. A lot of those things. A lot of you guys already know that anyway, so I won't belabor that. But you got to realize also glucagon and insulin both play an active role, and they're both present in the blood. Okay. Now, the ratio of the hormones determine which one dominates. It's like a husband and wife. Sometimes the husband is right. Sometimes the wife is right. More often the latter, of course. But blood sugar homeostasis, balance, is the ultimate goal, and that's the range we want them in, okay? Now, keep in mind, insulin is the dormant hormone of the fed state, meaning you're well nourished, you're well fed, okay? Secretion of insulin is affected by increased glucose, because if we're getting too much sugar in the blood, the pancreas has to spit out some insulin to get rid of the glucose. It has to open the receptors on the cells to let the glucose in, okay? Also increased amino acid concentrations. Feed forward effects of the GI hormones. So we have a big meal, we have all the hormones in our gut, the amylases and the hormones and all that to help digest food. All those will help trigger more insulin because it knows that you're going to have a high blood sugar in a little bit. Parasympathetic and sympathetic, depends on, a lot of it is environmental, okay? Hence stress can cause things. Now also keep in mind insulin promotes anabolism. That's why popular among the bodybuilders is IGF, insulin growth factor 1s, things like that. Insulin lowers the blood plasma glucose by increasing transport of most insulin to sensitive cells post-workout. That's why a lot of times right after a workout, it's okay to have a sugar thing. We used to take years ago creatine when it was just powdered creatine. There was no sugar in it. We would mix it with grape juice to get the sugar, because the grape juice would actually cause the insulin receptors on the cells to open. The sugar would cause them to open and let the creatine into the muscles, and you get your muscle flushing. Nowadays they have the formulas pre-built in. So they say after your workout meal you want a little bit of sugar or like white bread with a protein and some other things to get it into the cells. Okay. Now again, just think of insulin does promote anabolism, building up. Okay. It also will help white and brown fat synthesis. Okay. Now, glucagon is dominant in the fasted state. So if we're fasting or we miss a few meals, we get stranded someplace, then what happens is our blood sugar is going to start getting low. So the liver is going to start doing some gluconeogenesis, and then the cells in the pancreas are going to start stimulating the hormone to cause that to happen, to release glucogen or blood sugar to get our sugar levels back up so we don't go hypoglycemic, okay? Normally when the glucose falls below 100, it'll start dripping out some of the glucagon, okay? It'll start sending it out. Even though 70 to 110 is normal, that's why I was saying there's always a presence of both in the bloodstream. It's kind of like the rheostat on a wall for a light switch, kind of dimmer switch, but it always keeps it on, but not too bright. Again, liver, primary target of glucagon, stimulates glycogenolysis and glyconeogenesis to increase glucose output by the liver. I don't know why someone couldn't come up with easier pronouncing names years ago, but it is what it is. Glucagon release is also stimulated by plasma amino acids. So if you have a bunch of amino acids that are liquid that you actually ingest post-workout, it will also come on in and start doing that. Okay, so just keep that in mind as well. So real quick, I always like pictures. I'm a picture type of guy, so it makes a little bit more sense to me if I see an image of it. Our ideal is between 70 and 110 we want to maintain. So what happens if we're out and we can't get any food or we forget to eat lunch? Then, well, our homeostasis gets disturbed. Our blood sugars will start dropping. And what happens is our alpha cells will start to release the glucagon. That will cause increased breakdown of glycogen to glucose. So we're starting to lose a little bit of skeleton muscle here, which bodybuilders don't like and athletes don't like, but it happens. Also, if you notice, a lot of elderly, they don't like to eat as they get older. So what happens? They start losing mass. They start developing possible osteopenia, possible osteoporosis. This is one of the things, too, that can contribute to all that because it gets a little bit lower. Increased breakdown of fatty acids, okay? So that's why if you want to lose weight, you can jog in the morning before your meal because you'll start pulling from these guys. But immediately afterwards, here's the trick. I know you guys are going to ask on this. So here's the trick. If you want to exercise in a fasting state, you want to do a cardiovascular type thing, not so much a muscle breakdown thing like lifting heavy weights, but you want to do a cardiovascular thing because number one, that will start triggering this and it will start pulling from the fats and fatty acid, okay? Now, keep in mind your metabolism is going to be revved because of the cardio. So once that's revved after your post-workout meal, that's not going to go to the glucose storage thing in your liver to get transported into fat back to the adipose, the fat tissue. That meal is going to get burned in because your metabolism's already up. So that's why they say exercise a light cardiovascular one before a meal first thing in the morning is good. Obviously have some water before you do. Just a side note, not part of the lecture, but hey, always helps. Now, you can also do the increased synthesis and release of glucose in the liver. So all these play to get the blood sugar back up to get it back to this. The opposite happens when we're down here and we just gorge. We have like inhale a whole pepperoni pizza and now all of a sudden our blood sugars is going up. It's like, whoa, too much sugar in the blood. We got to get it out of the blood. So what do we got to do? So now the pancreas has to release the insulin. So it will do all of the opposite things. It'll increase ATP. It'll also increase conversion of glucose to glycogen. It's putting it back in. It'll start synthesizing proteins. It'll increase, what do we do with all this? Man, let's start tucking it away in our fat cells. We don't have any place to put it. Let's tuck it away. Well, can the liver keep up with detoxing if it's trying to convert? What do you want it to do, right? So what happens is it will sacrifice detoxing some of the chemicals of all the pizza and artificial pepperoni that you ate. It'll sacrifice detoxing them in order to keep the sugar levels low. So it starts producing the glucose and the glycogen, starts packaging that. So what happens? It throws everything in the fat cell. It'll go to that shunt. So keep in mind whenever you have all your stuff being stored in fat cells, you have all the toxins, you have all the extra energy, the fat molecules, the adipose, all that being tucked in there in the little packages, right? So what happens, and I'm really going on a side note, but I think it's pertinent to some of this. So what happens when you try to lose weight? When you first lose weight, the first few days, you're starting to dump pounds, and then, darn it, you always hit a plateau. Well, you're causing lipolysis. You're releasing all the fat stuff back into the stream, right? Because you're breaking open the little adipose cells. When that gets back into the bloodstream, you have your filtering organs, the kidneys, the pancreas, the liver. They're all doing the detox because all these things are released in the stream now. So they're trying to filter them. Well, sometimes they can get clogged. So what I always tell the patients whenever they were trying to lose weight, once we hit the plateau, we would do a 2-day detox. Then as soon as we did that, boom, they were right back on the losing. We cleaned the filters. So keep that in mind if you're struggling trying to lose weight to prevent diabetes. if you're at a plateau, do a detox. Your filtering systems are probably clogged up. I just had a couple of people, amen. Okay, yeah, I'm with you. So, so what happens once the liver is focused on this? It's not worried about detox, and it's trying to get the blood sugar levels down so it can go back to restored homeostasis. Okay. Now, let's talk a little bit more about diabetes. I want to go back into this here. We went off on a little side note, but I'm bringing you back full circle on this. So, just to remind you guys, it's a chronic disease, does not properly make or use insulin. And now we know why it doesn't make it or it doesn't use it properly. We have a good idea why. We just learned about some contributing factors, right? So keep in mind, insulin's job is needed to convert sugar, starch, and other food into energy by moving glucose from blood and into the cells. Now, just to recap on this, and we know why the reasons are, we just went over this. A lot of times the people with diabetes have increased sugar because of one of the three reasons. There's no insulin being produced. Remember the beta cells in the, or the alpha cells in the pancreas. Insulin production is insufficient. The receptors, because of the obesity, because of the extra hormone, because of the ER, has toned down the receptors. And also, again, the body's resistant to the effects of insulin because we're eating so much so often, we're overgorging, and it's having to pump it out. It doesn't work anymore, okay? So here's something to consider. As a result of high sugar in the blood, they will spill into the urine and out of the body. So a lot of times we'll lose sugar in our mind, in our brain. I'm not going to get into the other part of the endocrine system. Will actually trigger another hormone to say, hey, wait a minute, I feel shakes coming on. I want more sugar. That will make us crave more sugar. It's a negative feedback, okay? The body loses its main source of fuels and cells and is deprived of glucose, which is a needed source of energy. Because if we can't process all the sugar out of the blood, we sweat it out and we pee it out, okay? So what happens, let me just ask you guys, a lot of you guys may know this, but just think years ago, you have high concentrations of urine, sugar in the urine. That's still how we measure a lot of times. We'll pee in a cup, and they'll analyze it for that. How do you think they did that years ago when they didn't have instruments or the testing strips? Does anybody got any ideas? If you do, shoot it out. Okay, I'm getting a lot of guesses. All right, I'll tell you one of you guys was right. You're an old timer like me. Um, Years ago, the nurses used to actually have to. They would have the client or patient pee in a cup, and they would actually taste the urine. They wouldn't swallow it, but I mean I would hope not. But they would actually taste the urine, and they would report to the doctor if it was sweet, salty, or no taste at all, or if there was a pungent type taste to it. And that would go on the medical chart, and then they would alter the patient's lifestyle. They'd give them a medicine, come back a week later. So you think your job is tough. Imagine years ago having to be the nurse that did that. I couldn't, when I read about that, that was what they taught us in med school and in the annals of medicine, the history. That's what they had. Can you imagine going in and seeing 50 people on the books today coming in for diabetes? I would I would find a new profession. Now, type 1, let me just talk about this real quick, is basically which it's a disease of the immune, which the body system is fighting like an infection. Type 1 diabetes attacks the beta cells, right? Remember, beta does the insulin. Alpha does the glucagon. Insulin producing cells of the pancreas and destroys them. The pancreas can no longer produce insulin. That's why people with type 1 diabetes have to give themselves shots. Sometimes one a day, sometimes three a day, depends on the severity of it, right? We see it can occur at any age, but normally we see it in the younger population, okay? Whereas 15 years ago, if someone had diabetes, you always thought type 1 diabetes, you always kind of considered it had as a younger youth. It started and it went through the lifespan. If they had type 2, we always consider it adult onset, but things are changing, as we talked about earlier, because of the obesity crisis. Okay, type 1 is about 5 to 10% of the diagnosed population in the U.S. And I'm talking about U.S., not the whole world, but just in the U.S. Why is that only 5 to 10%? Again, I can't stress enough. it's because of the onset of type 2 because of our eating and lifestyle factors. No exercise, the high stress, and just the junk processed foods that's not even food anymore that America is eating in the obesity. That's why this is still small, even though the big one is type 2. Okay? Type 2 often provides response to insulin resistance, and we know why. I won't get into that. Type 2 used to be found in only adults who are overweight and over 40. Years ago, I couldn't remember the age, that's why I didn't mention it on the previous slide, but over 40 was a telltale sign, okay? Now, again, children in the United States are having those, mainly because they're overweight, okay? And I won't go on those, reading any more on this, but basically some of the telltale signs of this, diabetes insipidus and a lot of the other things, is normally you're going to be tired all the time, lethargy, thirsty, hunger, and you're going to be peeing a lot, okay? Obviously, you're peeing a lot because you're thirsty more. You can't get enough water. That's insipidus. So you can also start, and I didn't put it in here, but you can also start having blurred vision, having trouble seeing. So whenever a client comes in, if you're talking with them and you're doing a screening and you suspect they may have this, then you can also ask, hey, have you found yourself need an afternoon nap more often? Or can you not wake up in the morning? In combo, are you carrying around a water bucket on your back because you just can't get enough water in you? How's your eyesight been? Have you recently had to get your glasses checked, or do you need glasses now? You know, if you have 2 or 3 of those signs, then you need to start leaning into more about diabetes, and if they haven't been diagnosed, keep in mind most of the people don't know they have it, then they need to get tested. Okay, and we'll get an A1C test would be the better one, and I'll go into exactly what that is in just a second. Okay, basically, no matter what we're doing, we can't prevent it, we can't cure it, but we can manage it once we have it. Okay, so our idea of management is to help our clients maintain it within a functional level. We're not trying to cure it. Okay, type 2, the jury's still out on this. The advertiser, the slick marketing say we can cure type 2 diabetes. What we have found in my clinic and a lot of the other physicians is you can't really cure it. Once you have it, you have it. You're always predisposed to it, but you can really manage it where it doesn't affect your life anymore. It's off the radar screen. Doesn't mean it's totally cured because you've actually dumbed down the insulin receptors. You've already damaged them, but we can manage it by not having to utilize them as much or rely on them so much. Okay, so keep that in mind. So however, there are cures for diabetes, but they really help just control the disease, and that's what our role is. Massage is going to play a pretty big role in that, and I'll show you in a little bit where that comes in. The thing that the clients are struggling with right now, and the physicians that are managing this, it's a juggling act to try to keep that maintained. Okay, so what happens, we have to have, as a general rule, insulin or oral medication, and exercise activity makes the blood sugar go down. Food, which we have to eat, makes the blood sugars go up. Now, there's other factors that we're really starting to discover. Stress, injury, or illness can also affect blood sugar levels. That's why massage has been an integral part whenever we deal with a diabetic patient, because of the relaxation effects, not so much the physiological effects. Those are important, but gosh, just the psychological effects will actually help with the stress levels. Okay, now a lot of the people mistake this. I just wanted to hit on this real quick. Between the foods we just alluded to, the balancing act between fats, carbs, and proteins. Just wanted to make sure you guys understand this. Not all carbs are sugars, but most all will be converted into sugars. So basically, why is this? I put this in here because my mom and dad are diabetics and type 2. And when I told her to watch the sugars, the corn syrups, and all the pastries and all that stuff. So what does she do? She didn't buy those, but she went out and bought spaghetti. She bought pasta. She got the white potatoes. And she said, well, these are all carbs. They're not sugars. So I thought, you know what? I'm going to throw this slide in here. I'm going to put this in here. So you guys know this, or you should, that basically even the carbohydrates will get converted into sugars. It's a chemical reaction. I won't get into that. But basically it's the amylase, which is our digestive enzyme in our mouth, will convert it to a starch, which will go to the sugar maltose. Then it goes to galactose and glucose. I mean, there's a few other different chemical transformation. Then it goes to blood glucose. Now, the difference is some of the carbohydrates, they have to get things broken down a few stages before it gets to glucose. And it all has to do with the OH molecules in the carbons, okay? Some of the simple ones only need 1 or 2 steps and boom, they're right to glucose. So what happens is the ones that go boom right to glucose quick, they have a high glycemic index, which will cause a big sugar rush in the blood, which in turn needs a big insulin boost, a big insulin spike. Okay, so the ones that have a lower glycemic index, carbs, they will have a lot more steps in between the breakdown to get the glucose, and it gives your pancreas time to produce insulin and get it out in the blood without having to rush and just send the whole fleet army out there to combat the sugar. Okay, so keep that in mind. The other thing, if you do have a baked potato, a white potato, which is going to have a higher insulin spike or a higher glucose thing, it'll get broken quick, or white bread, try to have a protein with it, because a protein will, or a high fiber thing with it, because it will slow this breakdown process and it won't cause the big insulin spike. Not saying always eat a white potato with a baked potato, white potato with a steak. Not saying that, but if you have to have a high glycemic starch or carb, make sure you have a protein with it. Okay. Now keep in mind, I won't get into all this here. Basically, the insulin by beta is triggered rising glucose, comes on in, the GLUT2 receptor inside the cell will push it in, and that's what they make the powerhouse, the ATPs and all that stuff. We're not going to get into that. I'm going to skip over that. That'll be in your notes if you wanted to read it. I don't want to dive into the physiology on the cell exactly, and I'm not going to read you the whole slide here either. I'm just giving you guys a heads up. I won't kill you with that. But basically, how insulin works, it will get insulin is high sugars in the blood. Insulin gets released. It attaches to the receptor molecule, which will actually cause the ligated channels to open, which will allow the sugar into the cell, which the ATPs and all those, they get burned for energies. It's a whole physiological process, basically. The insulin binding receptors and everything else, they actually change a little bit. So, and you can read about this, and if you want to know more, there's tons of info on this. So that's kind of how insulin works. Again, here's what I was talking about. Again, I'm big with pictures. So inside the cell, outside the cell, in the bloodstream. So the insulin comes in. What happens is the sugar gets going. A hormone will stimulate these to become active. Then boom, they're like a magnet. They'll get in there. Then they open up and insulin comes on in. That's the insulin growth factors and all that will start coming in here. Then you start all the cell processes. A couple of you guys here are physiologists that are on here. I know because I recognize the names. You know what I'm talking about. I won't get into that. That's like a whole semester. So we won't go into that. But what about real world? What about what you're going to see on your table, and the clients are going to come in and say, yeah, I have my A1C tested today, I'm a 4. Or I have my A1C tested, Bob, and you know what, I'm a 9. Well, what does that mean? What is the A1C? That's a newer test. So let's learn about it in case your clients ask. And it's also good to write down what the A1C is in the charts. Okay? Diabetics used to only depend, like I said, on urine tests or the daily finger sticks to measure the blood sugars. They were accurate, but only in the moment. It was a time of reference. Okay, it was a TOR, time of reference. As an overall measurement of blood sugar, they're very limited. Now, keep in mind, the sugars can change throughout the day, even when you're not eating, even at night, with hormone changes. We learned earlier how the hormones can affect blood sugars because it's stimulated with sympathetic and parasympathetic. What happens if you have a bad dream and a nightmare? You don't know if it's real or not, so your body's reacting. You could have a surge, okay? Some people may have high blood sugars at 3 a.m. and be totally unaware of it. Well, how do we do that if we're not up sticking our fingers or peeing a cup? The A1C comes into play here. Back in the 80s, a lot of cool things came out of the 80s, guys. You know that, especially rock and roll. But this was one of the other things. A1C measures the average blood sugar I just got a thing says Quiet Riot and Van Halen were awesome. Yes, I agree. See, you don't leave chat on unless you have to. A1C tests measure the average blood glucose levels over the past 2 to 3 months. Okay, that way you're getting an average of it. Now, that is good because every time you eat, your sugar is going to go up a little bit, then it'll drop back down. This will also take in factor that, but it'll also factor in the other 7 to 10 hours when you're sleeping, okay? The other thing is they don't require a fasting because it's part of an overall blood screening. So no sense in fasting because it's not a time of reference. So what does it measure? What is the A1C? It measures, remember hemoglobin, that's our blood, measures the amount of hemoglobin in blood that has glucose, sugar, attached to it. Little sticky ball things that get on that attach to them. Heme is a product. Remember heme, the iron, ferrous, and all that stuff in the blood when we get into our cell biology, is a protein inside red blood cells that carry oxygen to the body. Hemoglobins are constantly dying and regenerating, but they have a lifespan of approximately 3 months. Wait a minute. In the A1C, 2 to 3 months? Yes. It measures the lifespan of this, the heme, and it tells how much glucose is attached to it. Glucose attaches or it glycolates to the hemoglobin. So the record of how much glucose, little hanging balls that get stuck on these, lasts for about 3 months. It has an imprint. If there's too much glucose, like over here, you will have a high A1C. If the amount of glucose is normal or low, your A1C will be normal. So what is the ranges? What is some of these normals? We're going to get into that. Diabetes, you should have an A1C test at least twice a year to find out your long-term control. People without diabetes, the normal A1C is about 4 to 6. Okay? For people with, the lower the A1C value, the better, to make sure they're controlling it properly, and the lower the risk of developing complications, glaucoma, eye disease, heart, kidney, everything else. For diabetics, the goal should be to have the A1 value less than 7%. Okay? That means the hemoglobin molecule will have less than 7% covered by glucose on it, stuck to it. Okay? Important to try. Maybe a hard target to hit, but it's important to try because the lower your A1C, the lower your health risk of all the other things that diabetes can bring. Okay? Some people actually check their blood daily and think they are actually good. So I put this in here because my wife asked this question, so I put this slide in. She said, well, if you're checking your blood daily, sometimes twice a day, do you still need to have an A1C test done if you've been diagnosed with diabetes? The answer is yes. A1C is controlled over the past few months. Some people are surprised when they have a high A1C because when they check their blood glucose with their meter, they have a relatively low numbers. Remember, 70 to 110 is the good range. So if you're doing that all day, but then all of a sudden you do an A1C test and it shows high, keep in mind it still may be triggering when you sleep, okay? When you don't usually check your blood and glucose levels, the other third of our life, okay? So it would still be prudent for this person that has a high A1C versus this to adapt a regular massage routine, stress, meditation, yoga, stretching, and diet that fits the lifestyle, okay, to try to lower the A1C. Then about 2-3 months, do the A1C again to try to keep it below 7. Here's where I found a thermometer gauge, and I put it on here for you guys. So basically, someone who is not a diabetic, never been diagnosed, will have about a 5% glycolated. So you're down here. Now, if your A1C is below 5.7, you really don't have to worry too much, okay? You're down here in the green. 6.5 or above would indicate diabetes. So if you're in the yellow, you got kind of like what's called the pre-diabetes. 6.5 to 7, you're about a pre-diabetic range. Right in here, you got pre, I just said that. Once you get up in the red, I thought I had a thing on red. Once you get up to 9 or 10, you're full-blown diabetes. You really need to be doing something here, okay? So, again, they say diabetics should do the A1C at least twice a year. Hey, most insurance covers this stuff. I would recommend a diabetic every 3 months. Every 3 months going on in, especially if you're trying to monitor the levels of it. especially if you are adapting new lifestyle changes. You're incorporating an exercise routine. See what it did 3 months from now. If you moved, if you've recently underwent an emotional trauma, things like that, you want to also check these, okay? Keep that in mind. Protein, carbs, and fats. I'll get a little bit about this here. Insulin. Then we're going to get into some of the massage. I know you guys are dying to get into some of the massage things and how we handle these clients. Basically, insulin's effect on carbs will facilitate into the muscle, facilitates the conversion to glycogen to storage in the liver and muscle, decreases the breakdown from glycogen by the liver. That's the role of insulin on carbohydrates. And I won't belabor this because I want to get into some of the other stuff. So you guys can follow along a little bit better. Protein, insulin's on protein, will stimulate protein synthesis. Remember the other slide that had the bodybuilders. We want to get into anabolism. It will inhibit protein breakdown and diminish gluconeogenesis. It will stop the liver, it will slow the liver from producing sugars. Okay? Yes, I just got a question saying, is that why taking the BCAA, branch chain amino acids, after a workout along with a protein powder is good? Yes, because on this, insulin will cause that, and that will actually help with the anabolism. That's one of the main reasons why the BCAAs work right afterwards. You want to take them right after a workout to get the amino acids in there. Fat. Insulin will stimulate lipogenesis, the transport of triglycerides to adipose tissue. It will start causing the storage, okay? It will inhibit lipolysis, the breakdown of the fat. So you're going to gain weight, you're not going to lose weight, okay? It prevents excessive production of ketones or ketoacidosis. Now, some of you may be familiar with that because of the Atkins diet. When you really cut out carbs, then you start pulling from the fat. And when you start pulling from the fat, that's when you break open the fat molecules. You promote lipolysis. And inside those fats, that's when you start burning excessive fats instead of carbs and sugars for energy. When you burn fats for energy only, then you can get into what's termed as ketones or ketoacidosis. Keto breath, they call it, like a sweet. Now, management, nutrition, glucose, meds, physical activity, and behavior. The last 5 years, these last two have really came on to play. It's always been about nutrition, glucose, and medications, but these have been really coming into play. So what is the difference between type 1 and type 2 management? Rule of thumb for type 1 is you have to have perfect timing. I'm going to say perfect, but very, very close to perfect timing of the meals because you're dependent on the insulin injections. You're injecting insulin in, and that has to work with the timing of the meals and timing of the insulin. You also have to monitor the blood glucose regularly. So doing an A1C alone isn't going to cut it. You have to do the daily plus the A1C. Okay? Type 2, it's a little different. We got to change our physical profile. We have to lose some weight, as we know now why weight, obesity, can trigger this and how it's related. We also have to have smaller meals because smaller meals, the ideal is to eat like 6-7 meals a day, but small meals, because that will not cause an insulin spike, a high sugar spike, which triggers a high insulin. We also see that some physical activity is good in type 2 diabetics, and again, blood glucose and any medications, you got to monitor those. These, along with the A1C, would be good as well. So you can see the difference in management of these between the type 1 and type 2. So, person with type 2, or type 1 for that matter, excuse me, can live a long, productive life and enjoy. What about massage? What are the benefits of this? What does the massage therapist need to know to handle and safely treat the person with diabetes? So a lot of you guys, I'm sure, don't have a questionnaire that has diabetes information on it for your clients. I recommend now, because more so ever, because we're going that direction, more and more having it, start making that part of your routine screening when you first introduce yourself to the client. Start talking to them, ask about diabetes. And just having a thing on there, say, are you diabetic, is not enough in my opinion. Saying, Are you a diabetic? No. Okay. Well, how often do you eat? Do you have your blood tested? Have you ever had an A1C? Is there anybody in your family diabetic? Go a little deeper in some of the questions. Before beginning massage, I always advise seeing us or their family doctor to make sure it's okay for a massage. Now, my opinion, person that has a diabetic condition, they should only be getting a massage if they're controlling the diabetes. If they're like at a 400 level blood glucose level, or they're not in control of it, then I think they need to gain control of it first before undergoing exercise, massage, anything else. Okay. Now, people should take some precautionary measures before. They should always inform the LMT or CNT or practitioner in advance, okay, especially areas of concern that they have, okay, and let them know that they're in control. The effects of a massage on a diabetic person may last for longer duration, hence the diabetic should check their blood sugar levels before and after a massage. I always recommended them when we first seen them to come on in. I always ask them what their blood sugar was that morning, and then right afterwards, within an hour, they would check the levels, and then when they would come in for their next visit, I would want to see the level change on that patient, so you kind of get a broad stroke. Now, we're also going to talk about diabetic neuropathy in a little bit, but one of the main complications of diabetes, another one, is diabetic neuropathy. So keep in mind, all of a sudden, like a deep pressure or hot stones is contraindicated for some of those right off the bat, and we'll talk about that in just a second. What's the bennies of massage? Well, obviously, there's no getting around the fact that massage can increase circulation, encouraging transport and everything else. It also will improve the insulin uptake. We can use that to our advantage, especially in vascular compromised diabetic clients that have peripheral vascular compromisation. We can actually really help the blood flow in these areas. And I'm going to say, I'll say it for the group here. I think we can actually help prevent limb loss and toe loss and circulation loss by keeping the massage and keeping things moving, okay, to be honest with you. So, and this is, in my mind, I chose these four images because I think they go hand in hand. We got to have massage because of some of the benefits that I listed there. We also have to have some light exercise. I think a sauna, a relaxation type thing, along with stretching, because the diabetics will have more fascial issues. So the combination of those four, not to mention the nutrition, I think you can not even have the symptoms if you do it right. Relaxation should not be underestimated, especially with the sympathetic and parasympathetic response that the diabetes can affect with the nervous system. Stress, anxiety really cause the blood sugar levels to go up. I know my parents, anytime something happens or they get an argument, even though if they eat the proper foods, they go out for the walk, if they're stressed, that night their blood sugar is up just simply because of stress, okay? Thank heaven we don't live in a world where stress is the norm, right? Okay, so keep that in mind. Relaxation and massage go hand in hand. That's one of the other benefits. The other thing is the myofascial effects. Now, I'm not going to get into fascials. I mean, we did whole webinars on fascials, fascial adhesions and everything else. Got two questions. Real quick, I'm going to do a quick pause and answer these. One was, okay, why does the stress and all that cause it to go up? Remember back when we talked about how the stress hormones, it's with the endocrine system, it will cause the pancreas to produce extra or slow it down, inhibit, and also the fight or flight response. That will make the blood glucose levels go up. So all that stress does all that. Second question, why does deep tissue chondritic in the extremities with diabetics? It is and it is not. That should be a political answer, politics. At first, when you first start working on a patient with diabetic neuropathy, you want to do a broad stroke and do a light one to assess their sensation, because some of them are hyper-magnified, and even having a sheet draping over the feet causes extreme pain. So they always say in the beginning, do very light ones to get going, and it's more compressive or acupressure type techniques. Once you get it going and you lower that activation threshold of pain, then you can go in and start doing some deep pressure versus stroking with friction. That's what a lot of the research states, and that's actually what we did with many of our clients. And I'm going to get into that a little bit. And yeah, Mike, it's actually compassion for the client. You know, you don't want to cause pain with them, obviously. Not unless you don't like them and you don't want them back. But then you refer them to a massage therapist you don't like. Now, that was a side note. So myofascial effects. What happens is a lot of the clients will have more of a thickening of the connective tissue because of the increased blood sugars that are predominantly in their bloodstreams. They'll actually have more fibrous adhesions, more restriction in joint mobility. All these things. So what we found, and a lot of you guys were on the stretching webinar we did, they loved the combination of the massage with a passive stretching. They really like that, our diabetic ones, especially with the lower limbs, the legs and the feet. They love the stretching. That was a huge one. So if you have a diabetic patient, I would encourage you to put some passive stretching routines in with your program. They will absolutely love that. Now, keep in mind, normally after a good massage, you don't just spring right up. Okay, you're a little kind of you're half in this world and you're half in another world, right? Diabetics kind of stay in that other world a little bit longer. They may have blurred vision. They can't, especially if they have diabetic neuropathy and you worked on their lower limbs, their proprioceptive sense of balance is probably going to be off for a little bit. So what we always did is we had a chair, obviously a lot of you guys do, right by your table. We'd have them sit upright for a little bit on the table, and we'd have them look at us. If they had like the deer in the headlight or a glazed over look, Saturday night at 2 a.m. look, then we kind of let them sit there. We got them some water or juice or something like that. Then we'd have them sit in the chair. We'd have them stand up. Then we'd walk them out. We would just take a little extra time. That's all I'm saying. So just make sure that they're okay, good to go before you let them hop in the car and drive on the freeway. Okay? Keep that in mind with your diabetic patients. Now, one thing that is also known is a lot of people, the blood sugar will actually drop, and it's been recorded up to 40 points during or right after a relaxing massage session for the reasons we stated previous. So we have to kind of use this to our advantage of knowing, because what happens if someone came in and they're at 90 or 100 points on the blood thing when they came in? That's why it's good to ask them to see their chart, their blood pressure monitoring. So if someone's at 90 or 100 and you do a massage and then all of a sudden you drop them down, then they may be hypoglycemic by the time you're done. They definitely will be a little dizzy, okay? Now, on the other hand, if they have a reading range about 140, don't let them eat anything, okay? So, because afterwards it's going to drop that 140 to 160. It's going to drop it back down into the normal range. Just had a question. What about timing right after lunches and stuff like that? Good question. So, we always, I wasn't the massage therapist, but, whenever we have our meetings, our staff meetings, we always talk to the therapist on this as well. And if it's right after lunch, we really never booked our severe diabetic patients right after lunch. We always kind of got them a little bit later in the afternoon. So keep that in mind, because you're playing with insulin spikes right after lunch. It could be really high, and we don't want to mess with that when we're working with the lowering effect too much. Also, if it's late in the afternoon, we always ask them if they had a snack, crackers with peanut butter or orange juice or something before the massage, because chances are late afternoon that's going to be dropping low, okay? So always ask them, and they should be monitoring them, okay? Higher than 60, some of them may consider taking an extra insulin injection. We had some of them, or rescheduling. Again, be careful if they take an extra injection. Try to calculate how much they drop. So the other thing to consider is, even after the massage for several hours, they may have a lower blood glucose. Okay. So I just got a question to ask. If it's the first time consult with a patient, do you massage on that very first day? Yes and no. It depends on the information. If they have adequate information and they can tell you and you feel good in your gut, a good clinical thing that they know their blood sugar levels and that they're taking care of it and they're managing it properly, then yes. But I would not do a full hour massage, and we'll get into that in just a second, for the first couple times. Then on the next time, I would ask them to bring, hey, when you come on in, bring me your numbers. Let me know what your numbers were after this massage. And you can tell them, a lot of times the massage will actually drop the points up to 40 points. So I'm curious, when you go home, let's do a finger stick and see what your massage is, or your massage, see what your blood sugar levels are, and then bring those reports into me and let me kind of know the next few days after the massage how your blood sugar levels fluctuated and what they were like. And people have no problem bringing them in because you're helping them and they're in control of managing it. It's something that they can control more, and they bring them in all the time. So that's a good thing to keep track of, and make sure you put it in the notes. Now, here's what I was talking about, the 60-minute one. We know that we just talked about that it can drop. So what we started doing was, when we did the initial case assessment, we always ask for the blood sugar levels and we put them in the notes and we try to, find out about them. For the first week or 2 weeks, instead of a 60-minute session, we did 2 to 3 30-minute sessions. And we monitored to see how their physiology and body habits would react to a massage with their diabetes. And we would have them monitor it, okay? And we would see how they are, because you don't want to go ahead and do a full 90-minute massage on somebody that you've never had experience with diabetes and drop at 60 points and cause hypoglycemia, okay? We also did combo stretching like I talked about it. Then we progressed the time increments as the client would adapt to getting massages. Now, if somebody has been going in for massages, we've had cases where they come in and say, yeah, we just relocated here. I'm wanting a new massage therapist. I'm a diabetic. I manage it. I get 90-minute massages every day. I want to lay on your table. Let's book a 90-minute. I know the money's nice and we want to make a living. But on the other hand, we would not do it. And we would tell them why and say, listen, for the first time here, we'll even give you a discount. We're going to do a 30-minute to a 45-minute for the first session, and let us see how you react to our technique and what we do. Because it is a new environment, there is different stressors involved, and psychologically that will have a little bit bigger effect. So let's just do that for the first time, and I'll give you 10% off the next one if you want to come in. We would do that, and if they didn't even want to do that still, then I got to be honest, we didn't want them as a client, because with us, that's a client dictating their care when you're the practitioner that's supposed to be helping them. So we didn't take them. We found with the severe diabetics, we didn't do any more than 60-minute sessions, because if they're on the table that long, first of all, they're immobile, and you could really, really lower the blood sugar levels. Even after an hour of being on a table, the blood sugar is going to start leveling out on its own naturally, and then you're in there working on it, causing it to go lower. We just didn't do it. We didn't do any more than 60-minute sessions. Again, we did a lot of 30-minute sessions, and the diabetics, people loved them. They had no problem with them, especially when we educated them a little bit on it. Now, what, I forgot that was in there. Yes, I am really dating myself now. Yeah, I just got to think. Yes, that was from Lost in Space. Very good. So you remember that. Now, because of the things, here's some of the warning signs we got to watch out for. Again, clammy, getting pale, you're having a sympathetic reaction, faintness, or they have a sudden onset of a headache. Again, that's a severe one, unable to awaken, but some of them will be very, very lethargic. Again, the Saturday 2 a.m. type thing, the stupor look, the glazed over look. They can be very, very irritable, or a sudden change in personality, or tachycardia, rapid heartbeat. So you guys all know how to take a pulse. I'm assuming you do. So we won't get into that. But always keep juice. We always had the little apartment refrigerators. You can buy them brand new at Walmart for $70. We always had little mini orange juices in there. And we always had a little thing of peanut butter crackers, 2 or 3 different kinds. And we always kept them there. Just because it's not a big deal to have someone take that if they're having one or more of those signs. And they really appreciated us looking out for them. So what happens if someone does have some of the signs afterwards It's not a big deal. They're probably used to this, to be honest with you. It's simple. If it's low, they just need sugar. So a lot of them, you ask them if they carry glucose tablets, and that's also a good thing to do with their intake. Again, a cup of orange juice or apple juice, something like that, grape juice with some crackers works well. And what happens, it will change within minutes. Sugar uptake is, boom, that fast, especially liquid. It doesn't have to be processed. So let them sit there for a little bit. Make sure they're feeling better. You'll see color coming back to them, and they may need to eat a little more. So that's fine. Or have them test the sugar again after a little while. You just got to ask, would it be wise to have a testing thing in your office? You know, we did. We had one in the back room where it's a generic finger stick, and we had some of the tabs if somebody wanted to test it real quick. It wasn't a big deal. You can also have a little pulse, like a pulse oximeter that clips on the finger without actually testing. You could do those. It's not necessary, but you know, is it going to hurt? No, because then you're getting, you can almost cross the line of diagnosing and getting a little bit more involved. But is it mandatory? No. I think the patients, a lot of times, if they're dealing with diabetes, they're used to this. They kind of know this, and as I said, it happens really, really quick. Okay, they bounce back. Now, with the awareness and precautions, you know, basically with diabetic neuropathy, it's best to use techniques of comfort touch, a form of acupressure or compression, like we alluded to earlier. You don't want to get in and start really torquing and doing things, especially if they have the diabetic neuropathy. And we're going to get into that just a little bit here. There's two types of diabetic neuropathy, or peripheral neuropathy. One is the diabetic neuropathy. The other is a chemotherapy-induced peripheral neuropathy from chemotherapy, cancer patients. Both are involved damaged distal sensory motor nerves, okay? Very painful to touch, okay? And friction and hot and cold, okay? Obviously, we're not going to talk about the chemotherapy one, but we're going to talk a little bit about the DPN one. DPN, I won't read all these, but basically there's causes of the 20 known. Diabetes is the biggest, okay? Then underneath that is chemo. The rest is some of the other things. But the peripheral neuropathy, they're going to feel like burning, itching. That just gives me the heebie-jeebies, that image, I got to be honest with you, with all the ants. Like some people describe it as bugs crawling all over their feet, especially at nighttime when they're trying to sleep. They'll get up, they'll start smacking, they'll think they're having stuff crawling on them. The other, you've seen the images on this, stepping on tacks. That's what it feels like, little tingling and stuff. We've all had our feet, we've sat crisscrossed legs, I guess that would be the proper term, for too long, or sat in a movie seat for a while, and our foot goes to sleep, and we get up, we're trying to walk, it's got all like pins and needles. Something like that, but magnify it times 2 to 3 times, but constant. That is what the numbness and tingling and pins and needles will feel like to them. So you can imagine living with that all day long and trying to sleep with that under the sheets, under the covers. So how you get around that is, like I mentioned earlier, instead of going right in and starting massaging and doing stripping on it, kind of doing compression first, then slowly work your way deeper. It adapts it to it, because you guys know what it's like. If you well, let's just be honest here, we're all adults. If you sit on the toilet too long, your feet go asleep. When you first stand up, you kind of notice it, and it's, if you stand there, then it goes away. It kind of doesn't cause the firing. But as soon as you take that first step, it boom comes right back with full intensity, right? Same thing applies for this. If you go in, you first put your hand on it, a broad contact is okay. Then you kind of work in slowly so you don't elicit that response. Now, keep in mind, almost 50% of all diabetics will eventually have symptoms of DPN. They'll all have that, okay? Now, you also have to watch, and I advise doing a scan of the lower extremities very, very carefully. Look in between the toes. Look through all things. Look for diabetic ulcers, okay? Because they don't heal because of the ones that don't monitor it and control it. They have a lot of lack of circulation. They can't get the circulation down there to heal properly, so they get diabetic ulcers. That's why they have diabetic socks, because it's a positive pressure sock that will actually help the blood flow get back in and out of the feet, okay? So keep in mind when you're dealing with these, look for the ulcers, look for the lacerations. There's also, you want to look for hot and cold spots. There's a number of things you want to look at. Again, deep tissue may be contraindicated at first. You know, use your judgment. Everyone's a little different. You can also ask for pressure if they can feel things. Kind of do it. It's a monofilament test. We would actually have a monofilament line, touch on the bottom of their feet, see if they can feel it. You could do the same thing with a Q-tip. Touch it, or your pinky finger. Ask if they can feel it, and then kind of go in a little bit deeper and deeper in your assessment, initial assessment, to find out how much they can feel. What's cool when you do this, if you press in and say, okay, I can start to feel it now. Okay, great. Monitor where that is. Make, kind of guess at. Put about 5-6 pounds of pressure. I went in about 1/4 of an inch pressure before they felt. Put that in your notes. The next visit, do it again. So for the first couple visits, start monitoring that and do that little test, and hopefully you'll see improvement of this, okay, throughout the thing. So if you get a Q-tip swab and tickle on the bottom of the feet or do a light little pressure, monitor where they have a foot diagram in your chart even, and monitor where they felt it. After 2 or 3 visits, start filling in. You'll see you can actually get more increased sensation as your visits go on, which is good documentation. It's proof positive, and it's kind of cool, to be honest with you. One of the things also, be careful with hot stones on there. Obviously, if they can't feel, you may be burning. They may not know it. I would almost consider a common sense one, so you guys just keep that in mind. A lot of people, if they do the insulin injections, find out when their last injection was. You want to wait about 2-3 hours before you massage any area around the injection site, okay? And ask them where the injection was. Left side, right side, thigh, upper arm, deltoid. Where did they do the injection? And if they ask why, and let them know, because sometimes the insulin doesn't get absorbed instantly. It kind of goes in there slowly, and if you massage that area, it will actually double the uptake. So be cautious on that, okay? Just got a question. I'm going to read it out loud if it's all right, Mike. Wouldn't faster absorption be good? No, because if you want to have a slower absorption, because you don't want a sudden drop. You don't want to go from a higher blood sugar down to a hypoglycemic. So that's why the injections are actually subcutaneous and not intramuscular, because they want it to absorb a little bit slowly. Okay, obviously you don't want to wait days, but you get the drift. Cool. Okay, got it. So what we always did is we always did a few things. We always examined the feet of the diabetic patient first. And again, we're not diagnosing. We're checking for our own records here. So we always examined first. We always checked for blanching of the toenails. And what I mean by that is, how you do a light pinch and you release it and you count how many seconds till the blood returns back to the nail. The nail better be white and it goes back pink, hopefully. Hopefully. So, and you monitor each foot, kind of like the big toe to the little toe, and kind of get an idea along the spread of the toes, how the blood circulation is. And then you actually do the other foot and you compare. Sometimes, I'm going to say 40% of the times, there was usually a discrepancy. One was a little slower than the other. So what does that mean? That means you may have to go a little bit more cautious on your touch, on your stretching, on your technique on that one limb until it catches up and you can kind of help rehab it a little bit. Cold spots. Sometimes you'll feel the foot and you'll find little cold areas. They're about the size of a little bit bigger than a quarter or a 50-cent piece, for those of you that know what I mean by a 50-cent piece. They're just a little bit cooler and colder. So again, on those you can push in, ask if they feel, if they have a loss of sensation, and you can actually push in, make it go white, then release and see if the blood returns normal. If you notice that throughout and it's kind of there, make note of it, and when you talk to their family doctor, if you do, or tell them to mention that to the family doctor, then make notes so you can monitor if it's still there on the next visit. Okay, so keep an eye on that. Also, obvious things: bluish skin, gray skin, black dots are cause for an immediate referral to the doctor because they have lost circulation. Don't massage those. Cold spot, not bad. Go ahead and do your light things. Obviously, don't press right on the cold spot. Do your massage. Any discoloration, stop the massage, get a referral, tell them and show the patient what's going on. Okay. Let me see here. Basically, I'm not going to go in here. Talks a little bit more about basically cramps, the neuropathy, about the nerves affected. I'll let you guys read that. Treating basically some of the treatments other than massage that we did. We coupled them. We did a cold laser therapy. Also, infrared has been really good at reducing some of the discomfort of neuropathy. Some of the things, if you wanted to make a flyer of this, basically how can massage, I've seen people do ads with this, how can massage help with peripheral neuropathy? Basically pain relief, circulate, these are the high points that you can put in an ad or an article or a handout that you can put, and that's all true, they help. And you can even type this in here. That's why I threw that slide in here for you guys. Okay, now, housekeeping, notes. We all know this. I covered all this. And again, forget that email. That one's not working right now. I don't check that one. Use the info at drbrianhawley.com. For you guys that are on here, I would love to show you guys how to get some of this stuff out, because we alluded to some of this stuff right here about using these as flyers or putting an ad in, stuff like that. I want to show you, and I think the image that I did, I'd like to show you a peripheral neuropathy ad that we did on Facebook, and it showed up on Instagram that I did for some of my clients that we manage their accounts, and it was just getting dinged left and right. People, they had something like over 600 hits on this thing, and phones were ringing. So if you guys are cool, okay, yeah, I'm getting some things. Yes, show us. Okay, so let's go into the live thing right now. I'm going to see if I can move some stuff around. So here is on, as you guys know, I do a well, maybe you guys don't. I also do a 5-week course on this. So we built a 5-week course page just for us to go in and play with. So I got you in the back thing on this here. So here is one of the ads that we did. We just threw this out here, and I did this for some chiropractors and medical doctors that deal specifically with neuropathy, doing laser treatments. And I actually had a massage spa that's wanting to really promote neuropathy. So this was the ad that I used, and how we would market this, and you could actually put different things in here. You know, I already posted this, so let's do this. Let's go ahead in here. So say we want to, do you have the 7 signs of, and you know what, whenever you're typing live, you always misspell, of diabetes. You could even put that in there, or 7 indications of neuropathy, whatever you wanted to put in, okay? So say you want to do that, and then what you want to do is you want to tie it in with a image. So we'll go ahead and put this in here. We'll find our image on our web page, or on our desktop. How about massage lower limb? We'll put that in. That's a good picture. Let's change this. Now for an Ayurvedic massage, click on image for specials, okay? So let's say we have that and we want to go ahead and do that. So I'm going to go ahead and hit publish as we're waiting. Again, that's the only thing that you got to do when it's going live. So that will go on live here. So there we go. So you can do that, and you can click whatever image you want. Now, for you guys that don't know this, some of the images will have writing in them. Facebook says you cannot have more than 20% writing on the image versus image itself. Okay, so you can only take up 20% of the space on the image with writing. You know, got diabetes, need massage, or April special, you can put on, but it can't be bigger than 20% of the image, otherwise it won't get approved. Now, you can put whatever you want up here. You could do things up here, okay? And sometimes below you'll have taglines as well, okay? Now, what do we do if we want to post this? What I'm going to do, I got two screens that I work with here. So I'm going to pull this off screen, open up my manager, and then I'm going to pull it right back. And the reason I'm doing this, guys, is because I have about 30 clients. I don't want to, go through everything. But what I'm going to do is this little thing, little inverted triangle right here, I'm going to click on that, okay? So bear with me. I'm going to pull this right over here to my other screen. And I'm going to drop that down. And I'm going to pull it right back. So hang on tight. And I'm going to go in what's called 5 weeks. It's going to go into the... I know you guys are waiting on this, so hold on. I'm coming right over. I promise. When that drop down comes, I'm going to hit Create Ads. And when I hit Create Ads, this is what's going to show up. It's loading my Facebook Ads Manager, okay? So whenever that comes up, see, if this was pre-recorded, I could do this and just edit it out, all the things, all the private contact info. But it's not pre-recorded. This is live. So that's what we're going to do. So whenever that comes up, here's what you're going to see. You're going to see that screen right here. So all we want to do now is hit Boost Our Post, okay? So I'm going to click that. We're going to boost our post. And what's going to come up, it's working. It's working slowly. You're going to find the page. In my case, my 5-week Facebook course is going to ask me to select that. And here's what it is. I'm going to pull it over here. Let it catch up. So when we hit Boost Post, this will come up and it'll show probably with you guys it'll only show one page, but with me, as I said, I got like 30 pages of all our client info that show up. I got to click the Facebook course page. So if you recall, we did Now Offering. So all you will do, if you pull up your clinic page or your office page, you'll click on this and it will show all the things in your news feed so you can promote these different ads. So this is one we want, and it's already selected. It defaults to the top one, but if you wanted that one, just click that. Then what we're going to do is set audience and budget. You guys with me so far? Okay, I'm getting thumbs up. Say we want to do Dallas, Texas. That's where our office is. Dallas, Texas. And we want to have them drive in, let's just go a 25-mile radius. Now, if you're in a big city like Dallas, a 25-mile radius, I'm going to get rid of Imperial Beach. If you're in a big city, a thing like Dallas, Texas, 20 to 25 miles is plenty radius. If you're in a small town, you may want to go outside a little bit bigger, 30, 40, 50 mile radius if you're in a smaller town. So right now we have a potential reach of 3 million people in Dallas that are on Facebook and Instagram, okay, on their cell phones, mobile phones, tablets, and desktops. Those people are aged from 18 to 65. So I would probably, for the diabetes one we're going to do, I'd probably target, let's just say 40 to 65 plus. Then what that's going to change to 1.2 million people. We still have a potential reach. Now, you want to do some detailed targeting. So I think, see, they have a diabetic right here because I did some ads already. So if we click pre-diabetes, that will come up. That changes to 5,000 people. What about diabetes type 2? That brings us to 27. What about diabetes mellitus? Just in general. That brings us to 79,000. And what about just say diet? 110,000 people. So right now we have a potential reach with these diabetes of 110,000 people if we lived in Dallas. That would give us a good range to work with. Now, what I would probably do is stop at this right here and I would continue forward with what I'm about to show you. And then I would come back and redo another ad, but pick a different audience. Type in obesity, massage, peripheral neuropathy, numbness and tingling, and do another thing like that. Pick 3 or 4 and do another ad like that. And I would probably come up with 2 or 3 ads with different audiences, and I would promote them. And then what I would do is see which one of those actually pull more clients in and make the phone ring. Because every area in the country is going to be different. You know, I can tell you what works here, but obviously I can't tell you what's in Dallas. I don't live there. And I'm assuming some of you guys don't. Not all of you guys do. So you want to go ahead and try different buzzwords or keywords in your area and put up there. So I like to keep it between 50 and 100,000 for big cities. Okay, so that would be fine for me. If you live in a smaller city, your numbers are going to be smaller. That's just demographics. So what do we do now? So we got our awareness, and you guys have probably seen this. If you wanted to even say you are getting people that are coming in that they have no money at all and they can't pay for massage. Fine. So let's do this. Let's go on down. I think demographics is the one. Let's look at financial. How about income? So we only want to target people that have, I'm going to say, $100,000 income and above. So we still have 200 in all this group. Okay? So if you want to narrow it, that's too big. So let's do this. That's our main topics. So let's put a narrow audience and get out of the main topics, and we'll do this. Let me show you here. Demographics, financial, income, and let's do that way. And I'll take this out right here. I don't want that in that column. And you'll see my number is going to change. So my number really plummeted when I did that. So I would change this up a little bit. So what I'm saying right now is the targeted audience I'm going to reach will have typed in, searched, liked, or shared, or commented on something with diabetes. But I only want to target the ones that have done that, plus they make 100 to 125,000 a year. Now, I could also change that to a little bit more broader. I would want to target a little bit more people than 6,900, but you can see you can get really specific on this. So you can actually target genders, ages. I mean, there's just a bunch of stuff you can do. So I'm just going to run with this for sake of demonstration, but I would change the income level. I'd even add, see, this is only doing between 100 and 125. You can also still do 125 to 150, 200,000 up. Everything above 100 you can do, and that will bring this number back up. So I would add all those in. So to recap, our audience is going to have, they're going to be between 40 and 65 plus. They're within a 25-mile radius of Dallas, if that's where our clinic was. They are searched, they've liked, shared, or commented on a post about diabetes, and they make over between 100 and 125, and I would add more income above 100. So that would be our target audience. How cool is that? Now, what do? We don't need to mess with any of that stuff. Let's go ahead and let me just take this out because I want that number bigger to show you guys. I would add more income levels, but for right now, I'll just take this out. Say we didn't care about the reach. So let's do this. So right now, if we wanted to, let's do it for $5, and we'll run it for 2 days for $5. We'll spend $10. Okay. So what's going to happen on Facebook? We're going to reach about 380 to 1,000 people a day that fit that target audience. Will be seeing our ad in their news feed. That'll be our daily budget of $5. We'll run it for 2 days. Let it run continuously, but we're going to shut it off in 2 days. So you don't have to mess with the start and end date in case you want to shut it off sooner. Let Facebook do the bids. They'll do the cheapest. Okay, this is the click-through rate. That means that we're going to pay for every time someone clicks on our ad and learns more about us. That's what we will do. Then what we'll do, once we have that set, We'll choose an ad creative. And a picture of our thing should, yep, there it is. That's what our ad will look like. Okay. And then what happens if we want it to go to our website URL, we'll put that right in there, and I'll just put just so you guys can see. I don't know if I can do that. I'll just put drbrianhawley.com, and you see the image kind of changed a little bit. So that website is linked to that. So now whenever somebody clicks on this image where it says click image for specials, it'll click on it and it'll take them to my website or a landing page. And I advise, I'm not going to get into how to build landing pages on this, but I advise take them to a landing page with only an offer, like receive 50% off your first 2 half-hour massages when you book for 4, things like that. I would take off the right desktop column and have in mobile newsfeed and desktop newsfeed. That is what I would do. So if you do that, and I'm not going to you'll hit place order. I'm not going to hit that because then I'm going to have people coming to my website from Dallas that are expecting me to massage them. So that's all you would do, and you would monitor it for 2 days. And you're only going to spend, say, $30 in total because you'll probably have 2 or 3 ads with the different audiences like I mentioned, and you'll see which one does better. And you can monitor that, and the ones that do better, then the ones that aren't performing, you cancel those ads. The ones that are doing better, you can allocate whatever daily monies you want to them. Just got a question. Can you say more about the charge for clicks? Do you pay for more clicks? How we do this is what happens is it'll show up in the news feed of those people every day. We don't get billed unless they click on that image and it takes them to the landing page or a website. So that's how we get paid. So what you don't want to do is have a thing where the people are just arbitrary. You want to get a good audience because you only want to pay for the ones that you really think they'll come in. You don't want to have kids clicking on your images. So just go ahead and do that. And again, it won't go over $5 a day. So that's how I do it for the clients. Now I get a little bit more advanced in my things, and you guys, there's actually videos on here. You could probably even learn about this. You can even put a pixel, a tracking pixel. If you do a landing page or the page on your website, whenever they click the image, it takes them to the landing page. You can embed what's called a tracking pixel on the landing page so it sticks to them. An example would be, so if you, yeah, that's right, it won't go over 5, Mike. Or whatever you delegate it to, it won't go over. So if you look on one day, you do a search for hunting boots, and then you go to bed, you get up next morning and you open your browser up and you're doing some searching, you'll see hunting boots showing up in the right column of your screen or whatever you search for. It's because one of the pages had a pixel attached to it. It gets caught in the computer's cookies, they call it. So why is this important to us? Because what happens is if you put a tracking pixel on your landing page, and there's videos in here how to do this, and you can Google YouTube how to put a tracking pixel and what they are. If you put them on your landing page, whatever potential customer goes to your landing page, your ad is going to show up in their news feed all the time, every time they're on there, which is very cool. And then it also helps you create audiences. In the other advanced things on here, and there's videos on this in here, you can actually create lookalike. It's called lookalike audiences in Facebook. So if you want to write that down and Google it, how to create a lookalike audience using Facebook, it'll show you all the people that clicked on the image. They have certain profiles, spending habits, age, demographics, zip codes. They'll have all those profiles, and then you tell Facebook in your next ad, target this lookalike audience, and they will target all the people that have those profiles, so you can really dial it into your customers. So is it cheaper than putting a $500 to $1,000 newspaper ad? Heck yes. Can you the thing I like about this, you can change the ads on the fly. You could do multiple ads and get results. If one isn't pulling, you can change it. Once you put an ad in the newspaper, it's kind of there and it's for a one-time shot. You know, if someone doesn't get the newspaper that day, tough luck. With this, it's on the newsfeed 24/7, right? So that's what I like about it. And you can change images. I've seen different images work better than others. So, and it all goes on demographics. That's why I say do $5 a day. I just got to ask a question. What's the average spend that we do? Normally for the first couple days, I'll throw little generic ads out to kind of see who and what the community in the area is going to respond to. I don't want to dump a lot of money into it. So I'll spend 15, 20 bucks. That'll give me a good idea. Once I got the idea and they're starting to respond, then I'll bump it up to $10 a day or $15 a day and start getting people coming in. I mean, there's one of the ones that I learned this from, he did a thing for Massage Envy. Now they spent like $3,000 on this, but they got 147 appointments booked in 1 week because of it. So it was Billy Jean clicks in the customers, and he did Massage Envy out here in California. He did a 1 week blast, or I'm sorry, a 2-day blast, and they got 140 some odd booked appointments. So you can dump money in, but so I always advise starting off at $5 just to do the test. Don't do $1 or something because you won't get it out there enough. $5 is adequate, and then bump it up to 10, 15, 20. Some of my clients I do, they want $50 a day on it. Fine, they're paying for it, and we'll just market to more people. So that's kind of that on how that goes. Is there any questions on the Facebook one? Because I kind of went over it a little quick. Does anybody got any questions? Okay, I got one. Can we do multiple services? Yeah. You can do one for general massage. You can do one for fascial stripping, hot stones, and diabetic massage. You can do those. You can have 4 different ads, but make sure whenever they click on the image, like if I click on this image in my news feed, I don't want to go to a hot stone thing. Make sure that the image, the link, is directed to the proper page on your website or the proper landing page. Does that make sense? Okay, yeah, yeah. So that's what you want, so you understand. So yeah, you can have as many as you want, and for all the different services, or if you're having one of them just asked, how do we track if they're coming from here versus word of mouth or on newspaper or referrals? A lot of times on this, what we'll do is on, not so much on the ad, but whenever they click and they go to a landing page, whatever the page is on, we'll say, hey, to get another 10% off, mention code 8675309, okay? Mention that code when you come in and you'll get another 10% off. That's a good tracking way. Some of them, the landing pages will have a coupon that they can print or cut. I hope that makes sense. I just got another one. Tanya, will this demo be included? Yeah, I'm recording the whole thing, Tanya. We'll just get it all out there for you guys. How's that? It'll all be in so you can watch it and play with it. And then you got my email. Shoot me an email if you have questions on this as well. I know this is just a quick demo of a 5-week course that I teach, so just that, but it's enough to get you guys to get in and play and know enough to what to look for and get some things out there. Cool. All right, I think that's about going to be wrapping up here. I got about 9 minutes before our 2 o'clock hour is up, and I promised you guys to get you out early, but it's been fun with question and answers, so I think we'll be doing this a little bit more often. If there's no other questions, then what we'll do, again, give me time to get this converted. It's a 2-hour recording, so it's going to take a while to get it converted and uploaded. You guys should be getting it tonight. If for some reason it gets lost in the internet thing, guys, just shoot me an email at info@drbrianhawley.com or hawleybrian@yahoo.com and let me know. Tomorrow's the weekend. I'll have my cell phone or I'll be at the computer. I'll just forward a copy to you directly from one of those two. Not a big deal. And I'll also include a mini test. And don't stress for you guys that haven't taken my test. My gosh, they're simple. It's just over this thing. An example of a question might be, hey, what was the social media platform Dr. Hawley mentioned? Well, the answer is going to be Facebook, right? So it's going to be like that. I have to have some proof that I did an exam for the CEs. And once you get that, just email me the answers and we'll be good to go. All right, guys. I'm going to go ahead and sign out. Start work on converting this and getting this out to you guys. I wish you all a good weekend. I hope you enjoyed. I hope you learned some stuff. So God bless and take care. I'll be talking to everyone soon. Take care, guys. Bye-bye.